Introduce our first plenary speaker. Please welcome Dr. Ada Adimora. Dr. Adimora is Professor of Medicine and Epidemiology at the University of North Carolina at Chapel Hill. She is also a member of the International AIDS Society Governing Council.
Good morning, everyone. It's my pleasure to introduce the first speaker this morning, Dr. Trip Gulick. He is Gladys and Roland Harriman Professor of Medicine and Chief of the Division of Infectious Diseases at Weill Medical College at Cornell University. He is also an attending physician at the New York Presbyterian Hospital in New York City. Dr. Gulick's research interests include designing, conducting, and analyzing clinical trials to refine antiretroviral therapy strategies for HIV treatment and prevention, and to assess antiretroviral agents with new mechanisms of action. He currently serves as principal investigator of the Cornell, New Jersey HIV Clinical Trials Unit of the AIDS Clinical Trials Group, which is sponsored by the NIH. Dr. Gulick is co-chair of the U.S. Department of Health and Human Services panel on clinical practices for treatment of HIV infection, and is also a member of the NIH Office of AIDS Research Advisory Committee. Excuse me. He's a member of the American Society of Clinical Investigation, the Infectious Diseases Society of America, and the International AIDS Society.
Good morning. Thanks very much, Ada, and thanks to the organizers for this invitation to speak this morning. I have no financial disclosures. Thank you for that. In considering what to start, I would like to pose three questions to you. How did we get here? Where are we now? And where are we going next? If we turn back the clock 20 years in July 1995, what was the situation with antiretroviral therapy? We had 4 approved drugs, AZT, DDI, DDC, and D4T. And we had one set of guidelines, which actually dated to 1993, to this JAMA publication from a state-of-the-art conference. And what did these guidelines recommend for what to start? For CD4s less than 200, or between 200 and 500 with symptoms, the recommendation was AZT monotherapy. For progressing disease or intolerant to AZT, change to DDI or DDC, and for all others, no therapy. Needless to say, we've come quite far in the last 20 years. Moving from July 1995 to July 1996, a number of events came together which really led us to the modern effective ART era. In the fall of 1995, 2 studies were presented to show the benefits of combination therapy. The ACTG-175 study and the European Delta study both conclusively showed that 2 nucleosides conferred clinical benefits over the use of a single nucleoside. In addition, a number of new antiretroviral drugs were reaching late clinical development and would be approved in this time period, and those included lamivudine or 3TC and 2 brand new classes, the HIV protease inhibitors, saquinavir, ritonavir, and indinavir, and the first non-nucleoside, nivaripine. In addition, what had prior been an investigational tool, the HIV RNA assay, was now routinely used to assess virologic activity of clinical trials. These 3 came together, and 2 studies really moved us into the modern era. I was fortunate to present on behalf of the study team the Merck 035 study, initially the preliminary results at a late breaker presentation at the CROI meeting in early 1996, and the final week 48 results at the IAS 1996 meeting held here in Vancouver, and this was subsequently published. We studied a zidovudine experience group who were randomized to receive either zidovudine 3TC, indinavir by itself, or the triple combination of zidovudine, 3TC, and indinavir. With that triple combination, we saw potent decrease in viral load level of over 2 logs, and most importantly, durable suppression through the end of 48 weeks. And we would ultimately follow this cohort through 6 years, and a majority of patients remained suppressed. At the same meeting in Vancouver, Julio Montaner, on behalf of the INCAS study, presented the results of the INCAS study, which looked at treatment-naive patients and randomized them between 2 2-drug regimens, but the 3-drug regimen of zidovudine, DDI, and nivaripine. And the INCAS study found very similar results. Potent decrease in viral load level, and importantly, durable suppression through the end of 48 weeks. These results were unanticipated, unexpected, and they led both of the study teams to try to characterize virologic response in a brand new way. That is, what proportion of patients are suppressed below the threshold of detection of the viral load assay. And that turned out to be 70 to 80% were suppressed to less than 50 copies on the 035 study, and between 60 and 70% were suppressed below 20 copies on the INCAS study. This was unprecedented and unexpected. Potent and durable regimens had now been found. But of course there were problems with these initial regimens. The first were side effects. Numerous side effects were associated with these medications, and these were troubling both to patients and to providers. In addition, these were cumbersome, not convenient regimens. For instance, this is what it was like to take this potent regimen of AZT, 3TC, and indinavir in 1996. At 8 a.m., swallow 7 pills. And then exactly 8 hours later, because this is an every 8-hour regimen, not a 3 times a day regimen, 6 more pills. And exactly 8 hours later at 12 midnight, 7 pills. That's 20 pills divided 3 times a day. In addition, you needed to take them fasting, either an hour before or 2 hours after meals. And finally, you needed to drink a liter of hydration to prevent indinavir-associated kidney stones. While life-saving, our patients spent their whole day figuring out when can I take pills and when can I eat and how many glasses of water do I need to drink. If the first 10 years of antiretroviral therapy was about developing potent and durable regimens, the next 10 years of therapy was to make them safe, tolerable, and convenient. And that's illustrated for you here. Andrew Carr reviewed this in a paper from last year published in PLOS One, where he looked at 114 antiretroviral studies, and they're shown in this bubble plot. The size of the bubble shows you the sample size of the study. And we're looking from 1995 to present day. He looked at studies that had at least 3 years of follow-up and were using the intent to treat analysis. And what you see here is what proportion of patients discontinued because of adverse events or side effects. Early in the mid-1990s, that was 10% or higher, but in more recent years, decreased to 4%. So the regimens have gotten safe and more, more tolerable. In addition, as we're all aware, co-formulations and pharmacologic boosting has led to improved convenience of our regimens, going from 20 to what was considered the holy grail of antiretroviral therapy when it was approved in 2006, 1 pill once a day therapy. We have additional 1 pill once a day therapies with branded medications, and of course generic medications have also used the 1 pill once a day strategy. Safer, more tolerable, more convenient led to better virologic responses. And again, going back to Andrew Carr's paper, this time we're looking at those same studies, but what proportion of patients were suppressed below detectable levels? And in the mid-1990s, about 47%, increasing by the year 2010 to over 80% of patients now suppressed below detection. Now, this is clinical trials, but we've also seen these results in clinical cohort studies. There couldn't be a better example than right here in British Columbia. In the year 2000, of all British Columbians taking ART, about 2/3 were suppressed below detection. But every year since, up until 2008, that number has improved. So in a clinical cohort, the suppression rate now 87% of all British Columbians. Before I came to Vancouver, we looked at our suppression rate at our HIV clinic at Cornell in New York City. Our suppression rate for people taking antiretroviral therapy, 90% in our clinic. These kinds of numbers are now being seen all over the world. Additional drugs were approved, additional strategies were tested, and that led us to the antiretroviral guidelines last year in the year 2014. Interestingly, still using the same recommended regimen as we did in the mid-1990s, 2 nukes plus a third agent. Interesting to review these guidelines because they converge. The developed world guidelines, the US DHHS, the IAS USA, and the European guidelines in 2014 all recommend the same initial 10 regimens for the treatment of antiretroviral therapy. Nuke combinations, either tenofovir FTC or in some cases abacavir 3TC, the non-nucleosides efavirenz or in some cases rilpivirine, the boosted PIs, atazanavir or darunavir, and the 3 approved integrase inhibitors, dolutegravir, elvitegravir, and raltegravir. Also converging were the WHO recommendations on a single regimen, tenofovir with either 3TC or FTC, together with efavirenz for all patients, adults, including pregnant women, and pediatrics. So where are we today with antiretroviral therapy? In July 2015, we have 28 approved drugs in 5 broad mechanistic classes: nukes, non-nukes, protease inhibitors, integrase inhibitors, and entry inhibitors. We have many one pill once a day options, both branded drugs and generic drugs. We've defined the optimal properties and maximized these over time: antiretroviral activity, safety and tolerability, convenience, and improving access and decreasing cost. As we've heard at this meeting, there are now 15 million people on antiretroviral therapy worldwide. Guidelines recommending up to 10 initial regimens with 1 standard strategy, 2 nukes plus a third agent. However, in the last couple of years, guidelines have continued to evolve. Why have they evolved? Additional head-to-head comparative studies of our first-line regimens. Some of the more important ones are summarized here. The ACTG 5257 study, published last year, was a large study of treatment-naive patients and a head-to-head comparison of 3 recommended regimens: raltegravir, boosted atazanavir, and boosted darunavir. And this study showed that raltegravir was significantly better in terms of responses than either of the boosted protease inhibitors, and in turn, darunavir was superior to atazanavir. The single study pitted a dolutegravir-based regimen against efavirenz and showed that the dolutegravir regimen was significantly better than the efavirenz regimen. And similarly, Flamingo showed that dolutegravir is significantly better than the boosted darunavir regimen. So head-to-head comparative studies of our first-line regimens have now gone on to influence guidelines, which are changing. The first one to mention are the Spanish guidelines, GACITA. These were released in January of 2015 and took a bold move, now recommending for first-line therapy 2 nucleosides, the standard 2 pairs, plus an integrase inhibitor, either dolutegravir or raltegravir. Note the removal of both non-nukes and PIs from the first-line regimens. The DHHS guidelines that I'm co-chair along with Cliff Lane from the NIH and Marty Hirsch from Harvard, we maintained the 2 nuke pairs, but now eliminated non-nucleosides and atazanavir from first-line regimens, leaving boosted darunavir and the 3 integrase inhibitors. And then most recently, right before we came to Vancouver, the British guidelines released a draft which eliminates abacavir 3TC and efavirenz from first-line regimen options. We'll continue to see the evolution of guidelines this year. I look forward to the European and the WHO updates on what to start. And as we've heard at this meeting, these conversations are now in progress. So what's next? We've come a long way. What's next with antiretroviral therapy? Virologic efficacy, we may be at its peak with the medications that we have today. But there are some newer approaches that are being tested in clinical trials. Investigational agents may add to what we have today. Cenicriviroc is an interesting investigational CCR5 antagonist, which also binds to the CCR2 receptor on the surface of macrophages, and that mediates inflammation. So could you get both an antiretroviral and an anti-inflammatory effect from the same drug? And that has completed phase 2 testing, as shown here. We've heard at this meeting about broadly neutralizing monoclonal antibodies. They're being developed for prevention, but also being developed for treatment. And these do have potent antiviral effects. 3 of the lead runners are listed here. Many other are in clinical trials. And we can expect that we'll see combinations of these agents and additional formulations which may allow infrequent dosing. How will these play into our current armamentarium of antiretroviral agents? We'll have to wait and see. Of course, some patients are infected with drug-resistant virus, and we continue to need agents that have activity against these viruses. Doravirine is an investigational non-nucleoside that has activity against viral strains with mutations that confer resistance to the non-nukes we have today. This is completed phase 2 testing, and we expect an update here by Jose Gattel in the next session later this morning. In addition, drugs with new mechanisms of action offer hope for people who have infections with drug-resistant viruses. The CD4 attachment inhibitor BMS 66308 will hear an update of the phase 2 results of that compound at this meeting later today. And in addition, a new mechanism of action, the maturation inhibitors, both from BMS and GSK, are either in clinical development, and we'll hear more about the BMS drug today, or entering clinical development with the GSK drug. Can we do better with safety and tolerability? Well, people are trying. One of the newer approaches is to look at lower doses of the drugs we have today. The Encore 1 study showed an efavirenz-based regimen with a lower dose of 400 milligrams was non-inferior to the standard dose of 600 milligrams in combination with nucleosides. And recently published was 96-week update showing durable responses with the lower dose. Darunavir at a lower dose of 600 milligrams boosted with ritonavir was the subject of a pilot trial recently published in AAC. And at this meeting, we'll hear about a reduced dose of atazanavir, 200 milligrams boosted with ritonavir compared to the standard dose. And again, you should attend the next session following this one to find out the results of these studies. Some new drugs are being developed with safety in mind. The new prodrug for tenofovir, tenofovir alafenamide, or TAF, has completed phase 3 studies, as published by Paul Sachs in The Lancet earlier this year, and showed that the new formulation was non-inferior to the standard formulation with less bone toxicity and the suggestion of less renal toxicity. And we'll hear 2 updates on these data, including a study presented by Gupta looking at TAF in people with baseline renal dysfunction. Can we do better with convenience? Co-formulations have been popular with patients and providers, and additional ones have recently either become available or are being reviewed by regulatory agencies. Cobicistat, now co-formulated with either atazanavir or darunavir, was approved in the United States in January of 2015. TAF will be combined with a number of additional agents and co-formulations, as you see here, either with FTC and elvitegravir boosted by cobicistat, FTC and rilpivirine, and the first one-pill, once-a-day protease inhibitor-based regimen, TAF, FTC, and darunavir boosted with cobicistat. The first 3 of these are under review by regulatory agencies right now. Rilpivirine will be co-formulated with an integrase inhibitor, either dolutegravir, or the investigational agent cabotegravir, which I'll say more about in a minute. New injectable drugs may offer hope for people that can't take, for whatever reason, one-pill, once-a-day therapies. Rilpivirine is available in a long-acting investigational formulation, which can be given as infrequently as once a month. Cabotegravir, which is related to dolutegravir, is a potent integrase inhibitor whose pharmacokinetics support giving the drug as infrequently as once every 3 months. These drugs may offer additional hope to people. They're being combined. The Latte 1 study, which sounds pretty good right about now, uses oral formulations of the two drugs and showed in recently presented 96-week results that oral formulations of these two drugs could maintain virologic suppression. And in progress is Latte 2, which also sounds good, which is using the same drugs but in their injectable forms, allowing infrequently dosed maintenance therapy. The standard approach to HIV therapy since the mid-90s has been 3-drug therapy. Could we get by with 2 drugs? Many people are investigating this. A potent 2-drug combination of a boosted protease inhibitor plus 3TC, either as initial therapy in the Gardel study or as a switch maintenance therapy in the Olay and SALT studies, all recently published, showed non-inferiority to a standard 2-nuke and protease inhibitor regimen. A boosted protease plus an integrase inhibitor has been investigated in several studies, either as initial therapy in the NEAT-001 study and was non-inferior to 2 nukes plus a boosted protease inhibitor, although at lower CD4s and higher viral load levels, this combination underperformed. In the second-line study following NRTI-based failure, the combination of a PI and an integrase inhibitor succeeded in being non-inferior to 2 nukes and a boosted PI. Dolutegravir is being combined in unique combinations, either with 3TC or rilpivirine, and a number of studies, either in initial therapy or switch therapy, are in progress. And I draw your attention to a poster, late-breaker poster today, which looks at the cost-effectiveness of a simple 2-drug regimen. What about access and cost? This is a map from UNAIDS GAP report last year, and it shows what are the governmental policies in different areas of the world for starting antiretroviral therapy according to CD4 count. And you can see wide variations across the globe. In blue, start at any CD4 count. In the lighter blue, start at a CD4 count above 500. In green, below 500. In yellow, below 300. And in red, below 200 or 250. Needless to say, the results presented in the START study and the Temprano study earlier this year support starting in all patients. And what we can expect to see over the next year is guidelines and government policies changing in response to these impressive results. In fact, we've already been told at this meeting that several countries have already adopted the treat everyone approach. Several additional countries in this map, including Chile, Thailand, and the UK. So access, if we can afford it, should improve. Speaking of costs, the cost of generics has dropped in recent years. For instance, the cost of a tenofovir, 3TC, and efavirenz generic pill for a year's supply, US dollars $139 a year. Can we do better than that? Not sure. What's the bottom line with HIV treatment and what we've accomplished? And that is we are promoting healthy survival in our patients. This was first looked at in the modern era by the Danish HIV cohort, which keeps records of all people in Denmark taking antiretroviral therapy. And they used these results to model survival from age 25. And this was published now 8 years ago in the Annals of Internal Medicine. The probability of survival in the so-called HART era for a 25-year-old was just over 30 years of age. That extended markedly with the early HART era to now have a median survival of age 50, and in what they called in this paper the late HART era, 2000 to 2005, where the median survival was now about 65 years. Many people made the point that this was not equal to the general population. But in the years since 2005, in the last 10 years, we can now say life expectancy approaches or even exceeds the life expectancy of population controls. Here's some data to support that statement. This is from the NA North America Accord cohort, following over 23,000 HIV-infected people from the US and Canada, followed from 2000 to 2007. There were over 1,600 deaths, and they used this again to model life expectancy for a 20-year-old with HIV infection appropriately treated with antiretroviral therapy. That life expectancy went from around in the year 2000 to about 56 years, but by 2007, that 20-year-old could expect to live to over 70. Still not quite that of the general population. But when they took a look at the subset of people who started ART with CD4s greater than 350, that 20-year-old could now expect to live an additional 69 years. That's age 89. That's better than the general population. How can that be? Well, many people have speculated that having HIV infection and being in care has numerous other benefits in preventing and managing diseases, and that may well lead to this enhanced life expectancy. Andrew Hill presented at this conference last year the relationship between the percentage of people being treated with ART, and it was directly related to the AIDS death rates, with countries treating more people seeing less AIDS-related deaths. And what that's led to is increased life expectancy worldwide. This is an illustration of the increased life expectancy in sub-Saharan Africa. Life expectancy increased from 1960 to 1990, but then took a precipitous drop in these countries through the year 2000. But now you see that that is rebounding with the advent of antiretroviral therapy. This supports what we've heard at this meeting, the 90% approach. 90% will know their status, 90% of them will receive ART, and 90% of them will be suppressed below detection. So what can we say about what to start antiretroviral? In conclusion, what do we expect next? Antiviral activity of our regimens may be maximum, but newer drugs offer additional strategies. Safety and tolerability can be improved, and we look forward perhaps to lower doses and certainly to newer drugs. Convenience could be improved for people that can't take one pill once a day therapy. Co-formulations and injectables, again, offer hope. Affordability, not clear that we can do better than what we do today. Accessibility almost certainly will improve following on the START and Temprano studies. And life expectancy, as I've emphasized, is the same or perhaps better than the general population. I didn't mention at all in this talk adjunctive treatment, which is the subject of many research studies, either to reduce immune activation and inflammation, and of course, cure. I'd like to acknowledge my university, Cornell, and the NIH supporting the ACTG and other groups that have done some of the studies that you've seen today, and of course the patient volunteers who contributed, and lastly a number of colleagues who gave thoughts and ideas. And I'd like to end really by saying that where we are today is the result of a number of people working together, from academia, government, non-governmental organizations, foundations, industry, and of course the community. And the efforts have really been worldwide to bring us where we are today with treating HIV. We should pause and consider our great success in how far we've come and look forward to making additional movements forward in this field. Thank you very much.